Hello everyone. Today's video covers 20 recall high yield pediatrics previous year questions asked in NEET, PG, INI-CET and other competitive exams with explanations. Okay. Now the first question. A 3-year-old child is brought to the emergency department with generalized convulsions. Okay. Generalized convulsions. This is the key word here in this question. Okay. Following a high grade fever. Now here we see high grade fever, generalized questions, 3-year-old child. Which of the following is the most appropriate first line medication to manage seizures in the acute febrile episode? Okay, so the options are diazepam, valproate, fosphenytoin and doxycycline. So first of all, we have to understand this case scenario. This is a 3-year-old child, okay, who has come to us with generalized convulsions, high grade fever, and he has come in active seizures, right? Now he has got fever and seizures. So in this age group, okay, 6 months to 5 years of age group, our most common working diagnosis will be febrile seizures, right? Febrile seizures. Now, if you look at the options here, doxycycline, amoxicillin is out. These two antibiotics, there's no role of antibiotics in that, okay, especially in the control of seizures in the acute phase. Valproate and fosphenytoin are anti-seizure drugs. They are ASDs, but they are not the first line of management, especially in febrile seizures. So, child has come to you in acute febrile seizure, febrile convulsion kind of scenario. Diazepam or midazolam, which are the group of benzodiazepines, okay, this is what you should administer in the acute setting, okay, when the child has come to the emergency department. So the answer here should be diazepam, which is a benzodiazepine. All right. So if diazepam or midazolam are the options, select that as the answer because the working diagnosis in this scenario is febrile seizures. The second question is, a child demonstrates progressive neurological decline, okay, and a cherry red spot on fundus examination. Enzyme analysis reveals a deficiency in hexosaminidase A. What is the most likely diagnosis? Okay. Now, the first thing is, clue here is progressive neurological decline. Now, that occurs in all of these options: GM1, GM2 gangliosidosis, Niemann-Pick disease and Gaucher disease. It occurs in all 4 of them. Cherry red spot also, yes. Although it is common in Niemann-Pick disease, it can also be seen in severe infantile forms of all the others, GM1, GM2, gangliosidosis and Gaucher. It can be seen in severe forms of those. Okay, it's not like it's completely absent. So again, neurological decline as well as cherry red spot is seen in all. Now, enzyme analysis reveals a deficiency of hexosaminidase A. Now, this gives you a clue towards GM2 gangliosidosis because in GM1 gangliosidosis, okay, the deficiency, it is because of deficiency of beta galactosidase, okay. So this is because of beta galactosidase deficiency, GM1. GM2 has Tay-Sachs disease, okay, Tay-Sachs disease and Sandoff, okay. These are the two over here in GM2, right. Tay-Sachs disease has hexosaminidase A deficiency. Sandoff is hexosaminidase B deficiency. Okay, but both of these, whether it is Tay-Sachs or Sandoff disease, both are under GM2 gangliosidosis. Niemann-Pick disease, we know that the enzyme deficient in Niemann-Pick disease is sphingomyelinase, right? Sphingomyelinase. And in Gaucher disease, there is deficiency of glucocerebrosidase, right? This picture here is showing you cherry red spot. Now, this is a spotter question for pediatric OSCE for your MBBS theory and, sorry, not theory, for your practical exit exam for MBBS and also This can be asked as an image based question in NEET. Okay, so this is the cherry red spot which occurs because there is deposition of the metabolites, okay, in the retina, okay, over here, and that loses its transparency. But this fovea over here, the ganglion cells are not present over here. Okay, so there is no deposition of that in this layer, and that is why this part, the fovea, maintains its transparency and is seen as a cherry red spot. The rest of the retina may become opaque, like what you are seeing over here, because of deposits of metabolites in the ganglion cells. So remember this, all of these are potentially, each of them are MCQ questions. GM1 has deficiency of beta galactosidase, GM2 has Tay-Sachs disease and Sandoff disease, each of them hexosaminidase A and B respectively. Niemann-Pick disease is there's deficiency of sphingomyelinase, and Gaucher disease is deficiency of glucocerebrosidase. Next question, 6-month-old infant. Okay, so here we all know because of hexosaminidase A, the answer is GM2. Third question is, a 6-month-old infant presents with frequent infections and failure to thrive. Okay, now this is frequent infections. Okay, clue is 6-month-old. That means early infancy, frequent infections, failure to thrive, obviously because of frequent infections also. Okay, tests show ADA deficiency, adenosine deaminase deficiency. Which immunodeficiency disorder is most likely responsible? Now, if you have a question where this particular clue is given, ADA deficiency, instantly that should ring a bell that this could be SCID, severe combined immunodeficiency. Okay, and what is the reason behind this? So ADA, this enzyme is utilized, or it is required for metabolism of toxic purine metabolites, right? Purine metabolites. This enzyme is required for the metabolism of these. But when ADA deficiency is there, these toxic purine metabolites, these get accumulated. Okay, these accumulate and they are toxic to the T cells, to the B cells, and natural killer cells, okay, NK cells. These are toxic to the lymphocytes, basically. These metabolites, they are toxic to the lymphocytes, okay, and because of that, these lymphocytes, T, B, and NK cells, their function is altered and they do not act appropriately in case of an infection. So severe combined immunodeficiency is the answer. So ADA deficiency, remember, severe combined immunodeficiency, SCID. Now number 4, a child with coarse facial features and developmental delay is found to have an alpha L iduronidase deficiency on enzyme testing. Which substances are expected to accumulate in this disorder? Now you have to highlight the points here, clues here: coarse facial features, developmental delay, and this particular enzyme deficiency. Now these two, coarse facial features and developmental delay, these two are very characteristic features of mucopolysaccharidosis. Okay, coarse facial features and developmental delay. Now this particular deficiency is seen in MPS type 1, okay, mucopolysaccharidosis type 1. Okay, the severe form of this is called Hurler syndrome. Okay, the severe form of this is Hurler. Okay, and what accumulates in this? Dermatan sulfate and heparin sulfate. Remember that. HD, heparin sulfate, dermatan sulfate. These two accumulate in MPS type 1, and the enzyme that is deficient is alpha L iduronidase. Now there is a simple mnemonic to remember this, okay, Hurler syndrome, HURLERS. So H is for HS megaly, that is hepatosplenomegaly. U is for unusual, okay, unusual facial features. Okay, like you can see in this picture, the facial features, these are unusual facial features, broad nasal bridge, okay, increased distance between the canthi, okay, flat facial profile, frontal bossing, etc. R is, it is autosomal recessive condition, okay, autosomal recessive condition, that is what the R stands for, okay. L is for the enzyme, okay, L, okay, I do, okay, L is for this L-iduronidase enzyme. E is for eye findings, eye clouding of cornea, okay, clouding of cornea because of deposition of these metabolites in the corneal layers. So there is clouding of cornea like you can see in this picture. R is for retardation, there is growth and mental retardation, there is retardation, okay. And S is for short stubbed fingers, okay. S is for short stubbed fingers, right. So remember this mnemonic because an MCQ which gives you clues on this, okay, the answer is likely to be mucopolysaccharidosis, okay. So in this case the answer is deposition of dermatan and heparin sulfate and the diagnosis is MPS 1, Hurler. Number 5, a family pedigree reveals multiple individuals with symptoms such as progressive eye movement limitation, retinal pigment changes, and disturbances in cardiac conduction. Based on these findings and the inheritance pattern, which of the following is the most probable diagnosis? Now here family pedigree is the only clue. They have not given how the inheritance is, whether there is skipping of any generation. They have not given any details of that. But there are 3 things they have given. Okay, one is progressive eye movement limitation, second is retinal pigment changes, and third is cardiac condition. So this particularly, the first one, eye movement limitation, that is external ophthalmoplegia, okay, that is external ophthalmoplegia. The second one, retinal pigment changes, okay, there is pigmentary retinopathy, okay, pigmentary retinopathy. And the third is cardiac conduction disorders, okay, cardiac conduction is affected, conduction defect, okay. Now this all 3, this is basically a triad which is seen in Kearns-Sayre syndrome, okay. Kearns-Sayre syndrome, you will see this triad of external ophthalmoplegia, pigmentary retinopathy, and cardiac conduction defects, okay. This particular pigmentary retinopathy, they may also mention salt and pepper appearance, okay, on the retinal photographs. And why this happens? Because there are hypopigmented as well as hyperpigmented patches on the retina, okay, lesions on the retina, and that looks like salt and pepper appearance. That's the name given to that. So if there is a clue where you have progressive eye movement limitation, cardiac conduction problems, and pigmental changes in the retina, you should think of Kearns-Sayre syndrome, especially if they have mentioned salt and pepper appearance, okay. What is the given picture suggestive of? Next question is this. Now this particular thing is claw sign, okay. This is the underfilling, what you are seeing here. This is defective filling of the dye when done a dye study, okay, when the dye study is done. So claw sign is what you are seeing in this picture, and this is seen in intussusception, right. Then next is a neonate presented with central cyanosis on day 2 of life. Now here the clues are: 1, it's a neonate; 2, there's central cyanosis; 3, it's on day 2 of life. On auscultation has a short systolic murmur. What's the likely diagnosis? Now since it's a neonate, okay, tetralogy of Fallot does not present in the neonate, even though it is a cyanotic disease. This cannot be the answer because it doesn't present in the newborn period, okay. PVC and ASD, both of these are acyanotic heart diseases, congenital heart diseases. Okay, so PAPVC and ASD are acyanotic. Transposition of great arteries, TGA. This can present with cyanosis, with central cyanosis in the immediate newborn period, and this can present with a short systolic murmur. Okay, so the answer here is transposition of great arteries. Okay, TGA. Coarctation of aorta is associated commonly with Turner syndrome. We all know this answer. Coarctation is associated with Turner syndrome. Okay. Now, what are the other features? Like you can see in this picture, there is narrow or high arched palate. There is low hairline, webbed neck, broad chest with widely spaced nipples, cubitus valgus or increased carrying angle, horseshoe kidney, streak ovaries, amenorrhea, infertility, bicuspid aortic valve, coarctation of aorta, and low set ears. Okay. So, coarctation of aorta, you should remember Turner syndrome. Noonan syndrome, usually the commonest heart disease is pulmonary stenosis, right? Pulmonary stenosis. And Down syndrome, the commonest heart disease is AV canal defect or endocardial cushion defect, right? Endocardial cushion defect. This is seen in Down syndrome. Turner syndrome, coarctation. Noonan syndrome, pulmonary stenosis. Okay. Pulmonary plethora is not seen in. Now, first of all, ASD, PDA, VSD. Okay. These three are left to right shunts. Okay. So, in these you can see pulmonary plethora. Plethora means the lungs have increased blood flow. On imaging, they may be plethoric, and that is usually seen in ASD, PDA, VSD. Tetralogy of Fallot, you will see oligemic lung fields. Okay, oligemic lung fields means, in contrast to this plethoric lung fields, you will see reduced blood flow through this. Okay, there's infundibular pulmonary stenosis, pulmonary infundibular stenosis, and oligemic lung fields. So, pulmonary plethora is not seen in tetralogy of Fallot. In a premature infant, PDA can be closed by administration of PDA, patent ductus arteriosus, can be closed by administration of prostaglandin inhibitors. We all know this. Prostaglandin inhibitors are what? Okay, NSAIDs. Okay, NSAIDs are prostaglandin inhibitors. So, what are the common ones that are used? Paracetamol. Okay, previously indomethacin, ibuprofen, and all were used. Okay, indomethacin, these are older answers. Okay, indomethacin or ibuprofen. Presently we use paracetamol, okay, for the closure of patent ductus arteriosus in preterm babies. So, prostaglandin inhibitors is the answer. Systemic hypertension is a feature of hypothyroidism, CAH, acute or chronic glomerulonephritis, and nephritic syndrome. Now, here the clear-cut answer is acute or chronic glomerulonephritis. Okay, because nephritis should immediately ring a bell in you. Nephritis is associated with hypertension. Okay, systemic hypertension. Hypothyroidism can cause low blood pressure. Salt losing congenital adrenal hyperplasia. Salt losing forms, okay, can cause hypotension. Nephrotic syndrome, because of third spacing, leakage into the interstitial space, and usage of diuretics, okay, that can also cause low blood pressure. Although it is not that it cannot cause high blood pressure, I am not saying that, but it is not very common. Okay, so the correct answer in this scenario is acute or chronic glomerulonephritis. So, where nephritis comes, you can safely consider this option as a cause for systemic hypertension. Okay, which of the following heart diseases do not present with congestive cardiac failure? Okay, now usually patent ductus arteriosus is left to right shunt. This can present with CCF, especially in preterms. Especially in preterm babies, it can present with CCF, and a child with PDA or hemodynamically significant PDA should be watched for signs of CCF, okay, clinically. Tetralogy of Fallot is a right to left shunt. It is a cyanotic heart disease, okay. Ventricular septal defect, again left to right shunt. This can go in CCF. Usually, VSD is identified at 6 weeks of life during a routine vaccination checkup. Why? Because until then the pulmonary pressures have dropped, and the murmur that is that is heard in VSD, the pansystolic murmur, is more obvious on auscultation, right? So these children also can go in CCF. Pulmonary stenosis, if the obstruction is severe, okay, severe obstruction can cause right ventricular failure, okay. Right ventricular failure can happen because right ventricular outflow tract is facing the obstruction, right? So pulmonary stenosis also is associated with CCF in severe cases. So which one does not present with CCF? The answer is tetralogy of Fallot. That does not present with CCF. Patent ductus arteriosus can, VSD can, pulmonary stenosis can. Oxygenated blood to the fetus is carried by umbilical vein, right? Oxygenated blood to the fetus. In this picture, you can see clearly, okay, this is picture of the fetal circulation. The umbilical vein, okay, umbilical vein carries the oxygenated blood, and umbilical arteries carry the deoxygenated blood in the fetal circulation, okay. So here you have to be very careful. Oxygenated blood is carried by the umbilical vein. All of the following are recognized features of Wilson disease. Increased copper content of the liver. Yes, copper deposition on the liver. Histopathological samples, biopsy samples of the liver will show increased copper content of liver. So previously, even now, there is diagnostic criteria for that. Okay, increased copper content of the liver, but now genetic diagnosis is more common. But this happens in case of Wilson disease. Second is histological features of chronic active hepatitis. Yes, okay, there may be histological features that there is an ongoing hepatitis, even though sometimes the liver function test may be absolutely normal on the biochemical test, but there may be histological evidence of hepatitis. Increased ceruloplasmin levels, no, this is wrong. There is reduced ceruloplasmin, okay, reduced ceruloplasmin below 20, okay. So that's the answer. This increased is not seen, reduced ceruloplasmin is seen in Wilson disease. Psychological disturbances, yes, neuro-Wilson can present with that. So which is not the feature? Increased ceruloplasmin levels is not the feature. Kerry-Combe murmur is seen in what? Kerry-Combe is seen in acute rheumatic carditis. To be very crisp, Kerry-Combe murmur is basically a mid-diastolic murmur, okay, and Kerry-Combe murmur may be, this mid-diastolic murmur is seen in Kerry-Combe. Kerry-Combe is one of the types. Then second one is in AR. This Kerry-Combe is in case of rheumatic mitral valvulitis, okay, when there is acute rheumatic fever and there is involvement of the mitral valve. That murmur, that mid-diastolic murmur is Kerry-Combe. In aortic regurgitation, the same mid-diastolic murmur may be heard, and that is called Austin-Flint murmur, right? Austin-Flint murmur. And the third one is the mid-diastolic murmur of mitral stenosis. Okay, so mitral stenosis that has occurred as a consequence of rheumatic fever, that will present with mid-diastolic murmur. So CAM, right? CAM is the mnemonic. Kerry-Combe, Austin-Flint, and mitral stenosis. All these, okay, Mid-diastolic murmur. These are types of mid-diastolic murmur, different names of the same thing. Okay. Tetralogy of Fallot usually will not present with a murmur. Hair on end appearance is seen in, we have all seen this picture, hair on end appearance is seen in hemolytic anemias basically. Why? It may be seen in severe hemolysis in case of thalassemia, okay, or in case of sickle cell disease, right? And why does that happen? Basically, there is bone marrow hyperplasia, okay, marrow hyperplasia. There is increased activity of the bone marrow expands and there may be spicules coming out from the skull. So hair on end appearance, this is an X-ray finding usually, and this is seen in thalassemia and other hemolytic anemias when they are in severe form. Which of the following is used in fetal therapy in congenital adrenal hyperplasia? Okay, fetal therapy. So here the options hydrocort, fludrocort, prednisolone, dexamethasone, all of them they cross the placenta. Okay, cross the placenta. But what is happening with the first three? With hydrocort, fludrocort and prednisolone, these are highly metabolized by the placental enzymes. Okay, these are metabolized by the placental enzymes. Okay, whereas dexamethasone crosses the placenta and it reaches the fetus in its active form. Okay, that is what is not happening with the first three. Dexa reaches the fetus in its active form and therefore dexamethasone is the drug of choice as for fetal therapy in congenital adrenal hyperplasia. To reduce what? To reduce the virilization of the fetus. Okay, and the last question for today is, which of the following intrauterine infections are associated with limb reduction defects? This picture is showing you limb reduction and scarring of skin. Now, this can be asked as a spotter in your OSCE, or it may be asked in as an image-based question in your NEET exam, right? So the answer here is varicella or chickenpox infection. This can cause limb reduction defects and scarring like this in the fetus. Okay, congenital varicella syndrome. So that's all for today, and stay tuned for further videos.